The most common complaint that every pediatrician encounters day in and day out is fever. Despite being such a common complaint, there are so many puzzles behind it. Today we have with us the right person to unravel the mysteries behind the second week of fever. Dr. Ram Gopal Krishna sir is a pioneer in infectious diseases. He has made a great deal of contributions to this field. He has guided many research scholars and has a lot of publications in Indian and international journals to his credit. He is a passionate teacher and a very approachable doctor. We extend a genial welcome to you, sir.
Good morning, everybody. So since I'm 2 meters away from all of you, I can afford to pull my mask down. None of you should do that, obviously. So the talk I've been assigned today is mysteries behind second week fever. And I assume this topic was chosen because the first week of fever tends to filter out all your common community-acquired causes of fever like malaria, dengue virus, influenza, and in this day and age, coronavirus as well. So this is kind of what I will cover. Fever of unknown origin by definition is certainly beyond 1 week and includes 2-week fever. How do you approach patients with second week fever? What tests to be done, and what's more important, what tests not to do, because these can often misguide you in terms of diagnosis. So if you look at fever of unknown origin, it is classified into 4 different settings, and based upon the setting, the differential diagnosis is completely different. What I will largely deal with today is classic or community-acquired fever of unknown origin, because that is what usually presents to a pediatrician. And these are some definitions. So these are the 4 types of fever of unknown origin. The classic fever is what I'll be talking to you about today, but occasionally the same syndrome can happen in a patient who is admitted to the hospital, that is nosocomial FUO. A neutropenic patient, typically after cancer chemotherapy, can have fever, and HIV-associated FUO carries a completely different differential diagnosis. So by definition, if you're having fever for more than 1 week, which is basically second week fever, you have fever of unknown origin. The temperature has to be more than 38.3, and you have to be evaluated several times, at least 3 times as an outpatient or 3 days as an inpatient. And so there is a certain cutoff. You can't say that somebody has long-standing fever or fever more than 1 week. That is fever of unknown origin till you have a basic workup. And the temperatures are also changing in terms of what normal human people have. We used to think that 98.4 was written in stone, but actually it's not. On average, our temperatures are falling by a small amount over a century or so. And current temperatures are actually lower by about 0.85 degrees Fahrenheit than what it was earlier. Where you measure also counts. The most convenient site to measure temperature is in the axilla. It is, however, the least accurate because it is close to the surface. So when you record fever, you need to mention where you're actually recording fever. And if you look at community-acquired FUO in terms of a practical definition, it's more than 99 in the morning or 100 at any other time of day. This is a useful practical way to look at it. And fever of unknown origin is when it persists for more than 3 weeks despite workup. And the common etiologies are either infections, autoimmune disorders, malignancies, miscellaneous causes, and finally undiagnosed. If you want to look at it in terms of commonality, obviously in a developing country like India, infections will be the commonest, but the etiology will differ based upon where you practice. If you are running a primary care or an outpatient practice, then the most likely cause will be typhoid, tuberculosis, or infectious mononucleosis. On the other hand, if you're practicing in a tertiary care hospital like ICH, you will see diseases like TB, connective tissue diseases, infective endocarditis, and in the last few months, multisystem inflammatory syndrome in children. And this is a recent publication from Christian Medical College, Vellore, which looked at fever of unknown origin. These were all adults, but it still illustrates some important points that infections are the most common cause of classical FUO, with extrapulmonary TB remaining the most frequent. Melioidosis is a very important emerging cause of fever of unknown origin. It is a common disease in India. Lymphoma is the commonest FUO, or rather commonest malignant cause of FUO, and SLE was the commonest non-infectious inflammatory disease causing FUO. And biopsies typically have a high yield in FUO. So this is an approach to FUO based upon Indian epidemiology. So when you have a fever in front of you that is going into the second week, you've done all your routine tests for typhoid, malaria, dengue fever, etc., and you don't know what's going on, then what do? The first thing you do is to take a good history. First of all, if a fever goes on for more than 6 months, then the chances are high that this is not an infection, simply because infections resolve or become very severe during that period of time. There's a high chance this is an autoimmune disorder. A malignancy also is not likely to go on for 6 months. If fever is very, very prolonged, say more than 1 year, please think of a non-infectious etiology for the exact same reasons I mentioned. Very unlikely it's an infectious etiology. In general, if you have a prolonged fever, you should lose weight and you should lose appetite. If appetite and weight are good, please think of thyrotoxicosis or sometimes even factitious fever. Sometimes children, young adults often manufacture their temperature rates. Now, we were always taught in medicine that if you have chills, then think of malaria. Yes, but even more important, think of a localized or a walled-off pyogenic infection, cholangitis, an occult abscess, etc. Remember, malaria is far less common than it used to be worldwide, and other infections are commoner than we think. If you have intermittent fever, in other words, fever comes, you're afebrile for a day or two and goes away, the classical teaching is malaria. But also think of hemolysis, especially intravascular or intermittent hemolysis, and autoimmune diseases, for instance, inflammatory bowel disease, which can often exacerbate, remit on their own. Diurnal variation is typical of diseases like TB, which are low grade and which just accentuate the normal diurnal change in temperature all of us have, which is higher or highest in the evening hours. But if there's no diurnal variation, think of typhoid. So these are all clinical clues based upon the history as to what the patient may have. You still have to take more and more history. What if somebody says they took a course of antibiotics, they got better, but then the fever came back? Think of an intravascular infection which will not respond to short courses of antibiotics, like say endocarditis, or a walled-off infection, say an occult abscess, a splenic abscess, liver abscess, or a prostate gland infection, something that is walled off, for which you need prolonged courses of antibiotics. I told you about long-standing fever, very unlikely it's due to an infection, and also go through all the treatment details the patient has had. If somebody responds to quinolones, then please consider tuberculosis, because we know quinolones are potent antimycobacterial agents. They will temporarily suppress the fever in any patient with TB. A response to antimalarials can be due to malaria, but it can also be due to an autoimmune disorder. Remember, chloroquine is used in the treatment of autoimmune disorders. If somebody has responded to antituberculous drugs, yes, it could be TB, but it could also be other rifampicin-sensitive illnesses. For instance, brucellosis, staphylococcal infections, they will all temporarily respond to rifampicin. Steroids, once again, will make the patient happy for 2 or 3 days. It's like a credit card. You pay, your bill is sorted out now, you just pay next month. So it just postpones your diagnosis. Social history is very important in these patients. Which parts of India, which parts of their local microenvironment have they gone to? What have they done? Have they played? Where have they played? Where has this child been exposed to? Outdoor exposure, any insect exposure, any animal bites, these are all critical, as is a family history of TB. The more recent the TB, the higher the likelihood that TB is in the differential diagnosis. We now focus on what we call PDCs. This is a new concept in second week fever or fever of unknown origin. It's a potential diagnostic clues. So these are all suggestive of particular etiologies. In children, high-risk sexual behavior, not very relevant except perhaps in older children, but water or outdoor exposure is very important. Diseases like leptospirosis, melioidosis, scrub typhus are all predicated upon outdoor exposure. You cannot get these diseases indoors. If there is a history of consumption of milk without boiling it, your antennae should go up for brucellosis, but also Mycobacterium bovis, which can cause lymph node tuberculosis. And obviously, anybody in this day and age who is eating out a lot, canteens, not at home, etc., think of a foodborne disease like salmonellosis. The physical exam is equally important, but there are certain areas you need to pay emphasis to. Skin lesions are critical because if you can't identify them morphologically, you can biopsy them. The oropharynx, the mouth is often the window to the body. Lymph node exam is very important, especially the supraclavicular and axillary nodes, because if you pick up an asymmetric lymphadenopathy, biopsy will give you a diagnosis very easily. Diastolic murmurs are more important than systolic murmurs, which can often be due to flow, and splenomegaly is always relevant because that drastically narrows your differential diagnosis. Now, these are all patients who have had eschars. Remember, when you look for an eschar, please look in flexural surfaces, usually those that are hidden by clothes. The mite likes to seek out warm or moist flexural surfaces. So please look in these areas or you will miss the diagnosis. This is a pictorial representation of where patients usually had eschars in a large study. So unless you completely remove all clothing and examine the patient, you will miss an eschar. So how will you work up second week fever? So first of all, start with your basics, a blood count, do a malarial test to rule out simple malaria, do simple tests like urine routine exam, liver function test, chest x-ray, ultrasound abdomen. It is important to do blood cultures, and I'll show you why. If you don't culture the blood, sometimes you will completely miss the diagnosis. And certainly in an older person or somebody with risk factors, you should do a HIV test. Now, blood cultures really are the cornerstone of diagnosis of many infections, and it is important to send at least one set. By one set, I'll show you the volumes that define a set. You mean one aerobic and one anaerobic bottle. And remember, the more blood you culture, the better your chances of making the diagnosis. Typically, we do at least 2 sets for every given episode of fever of unknown origin, but 3 sets are even better, especially if you are concerned about endocarditis. Now, this is the adult protocol, but I'll focus on the pediatric protocol here. Remember, the amount of blood you culture is dependent upon the weight of the patient. So, any child above the weight of 36 is essentially like an adult. You draw about 40 ml of blood over 2 sets of cultures, and the amount of blood cultured progressively falls with the lower the weight of the patient. If you don't culture blood in adequate quantities, you will miss the diagnosis. And this is actually the commonest reason for a missed diagnosis in patients, because adequate blood cultures are not performed before patients are treated with antibiotics. Now, this is a very interesting paper, again from Vellore, which looked at brucellosis. Now, how would you think you diagnose brucellosis? You diagnose it by a brucella serology, right? That is what is in your mind. No, all these patients had blood culture confirmed brucellosis. The modern blood culture kits are very accurate at picking up brucella. It'll grow on day 3, day 4, day 5. And it's impossible to make the diagnosis unless you do proper blood cultures. So in this paper, brucellosis was an unrecognized zoonosis entirely picked up on blood cultures. That is why the importance of sending off blood cultures in every patient with a second week fever. Then going down to your simple blood count. Dr. Revati spoke to you about the importance of pancytopenia, etc. But if you analyze each one of those indices from a fever standpoint, you can narrow your differential. Generally, infections don't push your hemoglobin to less than 6. If it's less than 6, please think of something else. It could be a primary marrow disorder, hematologic malignancy, etc. The white count is very important in kind of directing your workup of fever. If there's a low count, think of things like typhoid, TB, HIV, SLE. If there is polymorph leukocytosis, think of a pyogenic infection, but also a vasculitis. If there is a lymphocytosis, please think of a mononucleosis-like illness, say EBV or CMV. If there is eosinophilia, think of a drug reaction, a parasitic infection, or sometimes a lymphoma. And classically with typhoid, you should see an eosinopenia. So just by a simple WBC count, you can narrow your differential diagnosis. If the platelet count is very high, that is even more useful, because the differential diagnosis nowadays is MISC, right? MISCs, Kawasaki's, followed by pyogenic infection, any collection of pus anywhere or walled off infection, but sometimes even blood clots, even inflammation, vasculitis can cause thrombocytosis. If there is thrombocytopenia, think of malaria, SLE, HIV, etc. And pancytopenia was addressed in the earlier talk, but from an infection standpoint, think of something infiltrating the marrow, say disseminated TB, etc. But also think of HLH, which often causes a high ferritin. Now, people have asked me what is the correct test to do, a CRP or an ESR. Certainly CRP is less subject to other variables compared to an ESR, but traditionally we've always used an ESR as a useful screening test. Certainly an ESR more than 100 should always suggest something significant going on, things like TB, autoimmune diseases, pyogenic infections, etc. But so make sure every single FUO gets either an ESR or a CRP or both, especially in trying to decide what is serious and what is not. Similarly, if you have LFT abnormalities, you need to have an approach to these patients, right? Now, hepatocellular pattern elevation, which is basically elevated transaminases, suggests a viral inflammatory process or a drug etiology, say viral hepatitis, HIV, HEV, or a mononucleosis syndrome. On the other hand, if you have a cholestatic picture where the GGTP and the alkaline phosphatase go up disproportionate to the transaminases, think of something infiltrating the liver, or think of sepsis, systemic sepsis, or cholangitis, assuming that you don't have any abnormalities in the biliary tree. So never say deranged LFT. Classify your LFT abnormalities so you can have a working approach to these patients. A chest X-ray is often used as a screening test, but remember the pitfalls of a chest X-ray. It will not look behind the heart. So it has limited ability to interrogate the mediastinum or a retrocardiac infiltrate. Certainly it will not tell you what is going on with the pulmonary vasculature. And many patients with miliary TB, the millets are too small to be picked up on a chest X-ray. An ultrasound abdomen, again, is a cheap test. It's an easy screening tool. Look for hepatosplenomegaly, abdominal nodes, abdominal abscess. Also, it will clarify the etiology of deranged LFT or show if there's anything wrong with the renal parenchyma. But remember, this is, again, a screening test to help direct your workup. So in these patients, if you haven't had a PDC, a potential diagnostic clue, then you need to proceed with imaging. Don't worry about imaging in a child. This is a patient who's sick. Getting a single imaging test is something that has to be done. In this day and age, when we are doing CTs left, right, and center for patients with COVID, don't worry about radiation risk in these children. So you would typically do a CT chest if the chest X-ray is abnormal, your tuberculosis is high on the diagnosis, or if there are pulmonary symptoms, and a CT abdomen, especially if there are abdominal symptoms or if the LFT is deranged. And certainly in situations like miliary TB or mediastinal nodes with hypodense centers, they can often direct you towards your diagnosis. Other non-invasive tests are very useful in second week fever. For instance, urine culture. Don't do a urine culture unless the urine routine exam shows pyuria or there are symptoms of urinary tract infection. This is a common error made by general practitioners where they culture the urine and then treat that without looking for the true source of fever. And ANA, especially in a female, screens for SLE. Remember, false positive causes of ANA are as common as true positives. A serum ferritin is a very useful test if your clinical diagnosis is JIA, or the adult equivalent in adults, which is Still's disease. And LDH, as was shown in the previous talk, gives you a clue that there is increased cell turnover, typically coming from red cells. So hemolytic anemia, CPK for rhabdomyolysis, and TSH to pick up the occasional patient with thyrotoxicosis, a very useful non-invasive screening test for second week fever. Now, we are in the era of technology, and you need to use technology wisely. And the PET CT scan is the latest tool we have, not just for malignancy, staging, diagnosis, but for fever of unknown origin. This is very sensitive because it gives you both anatomy as well as physiology in terms of glucose metabolism. It's very sensitive. It can pick up a lot of things which are not the cause of fever, but the negative predictive value, in other words, if you have a normal PET CT scan, the negative predictive value of not having something significant is pretty high. One useful practical point, the fluorodeglucose uptake with an infection in abnormal tissue is usually less than 5. With a malignancy, it's usually more than 5. But it's not an absolute rule, but that's something that's useful to remember. So a lot of mainstream causes of FUO like TB, osteomyelitis, vasculitis are picked up. It is also useful for other infections such as intravascular device infections. If there are small lymph nodes, it can light them up, and it can direct you as to where to get your biopsy from because it's a sensitive modality. Remember, there are some pitfalls in PET CT, and we have what we call normal PET FUO. It can miss endocarditis, small lesions on the heart valve, you can miss completely. And what we're increasingly doing is, instead of, say you've done your chest X-ray or ultrasound, you don't have a diagnosis, instead of doing a CT scan, chest and abdomen, we straight away proceed to a PET CT scan because the radiation is the same. The cost is more, yes, but supposing your CT, chest, abdomen come back normal, you're double radiating the child if you do a PET CT afterwards. So currently, the algorithm for work and workup for FUO suggests you move straight to a PET CT, as I'll show you. The thoracic echo is especially helpful in certain situations. You have abnormal valves, say rheumatic heart disease, or you're worried about a complication of Kawasaki's disease, coronary artery aneurysms. It's very useful. However, sometimes we request the cardiologist to do a trans-esophageal echo. If you're really worried about posteriorly located valves like the aortic valve, mitral valve, or small intracardiac vegetations. So this is something you need to think about, especially in patients with risk factors for endocarditis. Now, this is a busy slide, but this is from a recent review article which suggests an approach to FUO. I've broken this down into 2 parts. Step 1, do a comprehensive history and physical. If you get a PDC, a potential diagnostic clue, you go after it. Say you find an Eschar of scrub typhus, your problem is solved. You go after that. If you don't, then you do all the routine tests that I talked about, blood counts, LFTs, HIV serology, blood cultures, etc. And if you still don't find anything, that is when you go for second-line imaging modalities, say a PET CT scan. So note that routine CT scans, CT abdomens don't have a routine role in these patients. If you have a PET CT scan available, you go straight for a PET CT scan. There's no point in double radiating the patient. So the approach for FUO has kind of changed over the years as we have these newer technologies available in terms of diagnosis. What about invasive tests? Whatever I've spoken about so far is non-invasive, should be your first method of testing, especially in a child. But sometimes you have a PDC which directs you towards the biopsy, a skin biopsy, a lymph node biopsy. Remember, this is again a very, very common error. If you're biopsying something, please send it for 1, 2, 3. I always teach saying biopsy means biopsy 1, 2, 3. And what is 1, 2, 3? 1 is routine histopathology, goes in formalin. Number 2 is cultures. You have to culture for tuberculosis, bacteria, and fungi. That goes in a sterile container. And number 3, this is the era of TB. You want to do a CB NAT, right? A cartridge-based NAT, like Expert MTB, again in a sterile container. If you put it in formalin, then certainly I will curse you when you send that case to me because you cannot process that sample if it goes in formalin. Bone marrow, Dr. Revati spoke about, but that is from a hematology standpoint. If you're suspecting infectious etiologies, do a bone marrow only if there are 2 cell lines deranged. There is, say, anemia, thrombocytopenia, anemia, leukopenia. The yield is higher if you have 2 cell lines deranged. And when you do a bone marrow, culture the marrow, do a gene expert on the marrow. All these things increase your likelihood of disseminated TB and other culture-positive infections. For instance, you may pick up salmonella only by a marrow culture. A liver biopsy is a far more invasive test. We try to avoid it because there is a small risk of bleeding. But in the setting of abnormal liver function tests, that is something you will need to do. Remember 1, 2, 3 once again. There are certain tests which you should avoid. It is time to tear up the textbook papers on some of these tests. Vidal, for instance, Vidal is a 130-year-old test. No role in medicine. TB serology, TB PCR. Throat swab cultures, because that just reflects your normal oropharyngeal flora. And ASO titer, never order that test unless you have clinical Duckett-Jones criteria for rheumatic fever. A malaria card test is also not a good idea because it can persist for several weeks after malaria is treated. Leptospirosis serology, that's often a big scam. A Mantoux. Now I know pediatricians like to do a Mantoux test, but that doesn't mean anything. About 30-40% of India is Mantoux positive. You need to make a diagnosis of TB, not just demonstrate TB exposure. And what is an IGRA? It's just a rich man's Mantoux. So walking through some of these tests, remember, somebody may have done this test, right? So it's up to you to interpret it, reject it if it does not fit the clinical picture or if it's a poor test. I'd like to emphasize once again, a Mantoux test is not a diagnostic test for TB. Repeat, it's not a diagnostic test for TB. All it demonstrates is that there has been TB exposure. It could have been recent, it could have been in the past, it could be related to what the patient has had in the past or something now. It's not a test for TB. And the exact same principle with the quantiferon TB, because it's called a TB gold, quantiferon TB gold. A lot of primary care practitioners think that the gold lies there. Not true. The microscopic agglutination test is another big scam. So again, this is something we have moved away from. The correct titer for Chennai is actually 1 in 400. But if you look at these labs, they will report a positive test of 1 in 100. Remember, the sensitivity, specificity of these tests is pretty low, and the sensitivity in the first 15 days is only 17%. So it's really quite a useless test. So again, other tests for leptospirosis like an IgM, ELISA, duct field exams, not very reliable. So how do I diagnose leptospirosis? I treat the patient with doxycycline. If a child tells me they've been exposed to a contaminated body of water, eyes are red, or there is Wild syndrome, don't worry about the diagnosis, just treat the patient, because diagnostics are poor with leptospirosis. Sometimes you will need to do therapeutic trials in these patients, and that should really be the exception rather than the rule. The days when all FUOs in children, you write out antituberculous drugs and then say, see you later, those days are gone. You need to make a diagnosis, largely because we are in the era of drug-resistant TB. It is not enough to diagnose TB anymore. You need to know whether it is MDR TB. You need to know whether it is isoniazid resistance. There's at least 15% isoniazid resistance in TB in Chennai as we speak. So there are sometimes therapeutic trials which other doctors may use before the patient sees you. Is there a role for any of these? Antimalarials, no. Its historical interest, giving antimalarials empirically for malaria, has been given up by WHO 12 years ago. So please don't give antimalarials to your patient. Make the diagnosis. A QBC, especially if repeated, very, very sensitive. We even have malaria PCRs, which are even more sensitive. And please don't give chloroquine as a therapeutic trial. Any fever will get better. If you're going to give an antibiotic trial, it should be an educated guess. Somebody has a typical clinical picture of typhoid, eosinopenia, then it's appropriate to give anti-typhoid therapy after drawing blood cultures. Similarly, if you suspect scrub or leptospirosis, you start doxycycline and then you think later. But avoid quinolones. We are moving away from quinolones in infectious disease, because these drugs cloak TB and they have a lot of side effects and they don't work for typhoid anymore. So it's a long time since I wrote a prescription for a fluoroquinolone. What about antituberculous therapy? Now, never give blindly. Now, that is just poor clinical medicine. However, sometimes when you have an inaccessible site, there's a small lymph node that you can't biopsy, or when there's a very recent history of family contact with TB, then that's something you can consider. But when you start ATT, always reassess in 2 weeks. If the patient is not better, then it's something else. And always remember, is the rifampicin component of ATT treating something else, like brucellosis or a staphylococcal infection or something else? So be careful when you give ATT trials. What about steroids? Really no. In this day and age, we do use a lot of steroids for MISC, multisystem inflammatory disease, but generally don't give steroids. If there's an infection that you're missing, you will get into deep trouble. So having spoken to you about all these patients, let's just run through 2 or 3 typical second-week fevers and see if you can apply these principles to make a diagnosis. First case is a 12-year-old male with fever for 2 months. Gets better with antibiotics, but relapses on stoppage. You can feel the spleen tip. The white count is slightly high, polymorph predominant. There are a few red cells in the urine. LFT echo are normal, and blood and urine cultures show no growth. So what would be your diagnosis here? I'll give you some options. So what would you do next to make a diagnosis? CT, bone marrow, ferritin, TEE, trial of IV antibiotics. So obviously your diagnosis has to be right for your therapeutic, for your diagnostic test to be right. Yeah. So this is probably endocarditis. Probably, the reason I say that, a lot of small clues. There is splenomegaly, there is microscopic hematuria, which suggests glomerulitis. It responds to antibiotics, but you stop antibiotics, it gets worse. So obviously something that requires a prolonged course of antibiotics. So this is probably endocarditis. If your blood cultures are negative, you should get a TEE to see what is going on with the heart valves. Next case, 14-year-old female with fever for 3 weeks, small lymph nodes in the neck and axilla. WBC is 4,000 with a lymphocyte predominance, 55% lymphocytes. The liver enzymes are elevated about 3-fold. HIV is negative. What do you think this is? So what next? Would you do a lymph node biopsy? Could this be a lymphoma? Would you do a bone marrow exam? Some marrow proliferative disorder? Is this SLE? Does this look like typhoid to you? Or would you do an EBV serology? Okay. So this is EBV VCA IgM. And the clue here is the age of this patient. It's a 14-year-old female. So, you know, in the olden days, they used to call this kissing disease, right? So this is a typical risk factor for EBV, and this constellation of lymphocytosis with hepatitis with small lymph nodes should always suggest the diagnosis of EBV mononucleosis. Remember, very self-limited disease. Next case, 8-year-old female with intermittent fever for 6 months, comes and then goes. Occasional arthralgia in the fingers and wrists, occasional oral ulcers, pain in the left chest on deep breathing. Chest X-ray is normal. White count is 4,000, and there are significant lymph nodes in the neck bilaterally. So what next? Would you biopsy the node? Say lymphoma. Would you do a CT chest, say looking for TB, RA factor, ANA, or a trial of ATT? Yeah, so this is relatively easy. The correct answer here is ANA. You can see here that this patient, these are criteria for SLE, has several criteria for SLE, the pleuritic pain, the polyarthralgia, it's a female. So these should always direct you. Remember, SLE often presents with fever of unknown origin, right? They don't go straight with classical joint pain. So think of this diagnosis in every FUO. Next case, 7-year-old male with fever. There's a pronounced weight loss, 6 kilos, and increased bowel movements for 2 months. Appetite is good. Mantoux, 14 millimeters, big Mantoux. Blood count and LFT is normal. CT chest and abdomen are also normal. So extensive workup, essentially normal. What next? ATT trial because of the big Mantoux. Echo for endocarditis. A PET CT. Expose one more radiation course of antibiotics for typhoid, common things are common, or get a TSH. Yeah, again, this is fairly easy. This is thyrotoxicosis, right? So remember what I told you about thyroid disease. Typically, this is one syndrome where appetite is good, and yet there is pronounced weight loss. There is also some diarrhea. So all these are clues to a very useful non-invasive test to make the diagnosis. You look like a star in front of the patient when you make this diagnosis. Next case, 4-year-old girl, fever for 10 days, high-grade, continuous, myalgia, headache, vomiting, has gone to rural Andhra Pradesh. 3 weeks ago, was playing outdoors with friends and relations, didn't respond to cefixime for presumed typhoid. Exam, there is a rash and there is some icterus. White count is high, platelets are slightly low, LFTs are slightly deranged, including jaundice. MP is negative, blood cultures and screening imaging is normal. So what do you think this is? So I would define this as doxycycline deficiency, right? So whether you see this or not, the patient is begging for doxycycline. So anytime you have this constellation of symptoms, right? Slightly high white count, deranged LFT, slightly low platelets, outdoor exposure, you start with vitamin D. Vitamin D is doxycycline. So please start with that. Don't worry about the side effects. One course of doxycycline will not stain your teeth. Don't worry. So this is scrub typhus. And you may or may not see this, but if you see this, it clinches your diagnosis. This is a 4-year-old boy, fever for 6 weeks, low grade increase in the evening, there is weight loss, there is slight cough, improved on ofloxacin for typhoid, has traveled to visit family in another state. There is slight anemia, WBC is 4500, ESR is 77, Mantoux negative, X-ray ultrasound normal. The alkaline phosphatase is slightly high, Vidal is strongly positive at 1 in 160. What do you think this is? Typhoid? No? So this is where you need to make a diagnosis, right? So the Mantoux is negative, so don't move away from TB. Now if you do a CT chest, this is what it shows, right? So remember, ignore tests for latent TB when you work up for TB. Tests for latent TB are exactly that, to tell TB exposure. If you have a family contact, you want to screen people, you do tests for latent TB, not in patients who are actually sick. So this is likely to be miliary TB. Next case, a 6-year-old male, fever for 4 weeks, up to 104. Each time there is fever, there is a transient rash. The child is well otherwise, some arthralgia, exam only pallor, hemoglobin is 9.2, white count is high, ALT is 80, ESR is 96, and essentially other workup is negative. So what do you think this is? Yeah, so how will you make the diagnosis here? You have a very good non-invasive test. The serum ferritin was very high, 6082. So what is this? This is likely to be juvenile idiopathic arthritis. So remember, this is how patients present with fever, and the clue was that transient fever with a rash. And if you look at textbooks, in fair-skinned populations, it's described as a salmon pink rash. So this is my last slide. There is no such thing as a blind approach to second week fever. Use your blood count, just a simple CBC, and your LFT in directing your workup towards potential diagnostic clues. Avoid empiric antibiotic therapy unless typhoid is strongly suspected, or perhaps unless lepto/scrub are strongly suspected. Avoid empiric antimalarials, absolutely. Avoid steroids. TB remains the commonest cause of fever of unknown origin in India, and a second week fever is rarely a mystery if you have a systematic approach. Thank you very much.